Good afternoon, everyone. Thank you for joining us today's lecture titled Wound Care 101, Wound Healing Phases and Evaluation. My name is Sibel Clifford, and I'm the Executive Director of the ABWM Foundation. The Foundation supports the work of the American Board of Wound Management for the advancement of wound care. Today's lecture will be recorded and be available on demand from the ABWM Foundation website. If you have any questions during the presentation, please type them in the question box in your Zoom control panel, and we will bring them up during the presentation. Now, I will turn it over to Dr. McCullough, the chair of the ABWM Foundation. Dr. McCullough.
Thank you, Sibel, and welcome to all of you this afternoon. We're so glad to have you with us. Our lecturer today is a good friend of mine and a physical therapist also. It's Dr. Dawn Franceschina. Dawn was certified as a wound specialist and currently works at the Advocate Aurora Lutheran General Hospital Wound Care Center in Niles, Illinois. She's worked with patients with wounds in the inpatient and outpatient care setting for over 21 years. Dawn has been a guest lecturer also at Northwestern University for 20 years, teaching wound care to students in the Doctor of Physical Therapy program. She received her CWS certification in 2002 from the American Board of Wound Management and has served on the exam review committee for the past 10 years. And in 2019, she was elected to serve as a trustee on the ABWM Foundation board. I want to thank you, Dawn, for providing this continuing education program today, and we're looking forward to hearing what you have to say.
Great. Thank you so much, Joe, for that introduction. And thank you to the ABWM Foundation for allowing me to be with you this afternoon. Welcome to everybody who is here. Thanks for carving out some time in your busy schedules to attend this presentation. I want to present this material to you, this introductory level course, regardless as to where you're at in your own practice setting and your years of experience. I'm hoping that this topic will be either a refresher course for you if you're a more experienced clinician, or will meet you where you're at if you're more of the entry level or newer to the wound care world of practice. So, and as you can imagine, this is a topic that covers a broad variety of disciplines as well. And so on this recording, I wouldn't be surprised if we have nursing assistants, if we have nurses, if we have physical therapists, occupational therapists, if we maybe have physicians or mid-level providers here on this presentation today. And so covering a Wound Care 101 topic is actually fairly daunting when you're trying to cover all of those different areas of practice with all of our respective areas of education and years of experience, our different practice settings. And so this is not meant to be an all-inclusive 101 level of the basics of wound care. We're really focusing today on wound healing phases and then evaluating a patient with a wound. And so that being said, let's go ahead and get started. So some learning objectives for today. By the completion of this presentation, I'm hoping that you as the learner should be able to identify the 3 different phases of wound healing, list at least 4 essential components of performing an evaluation of a patient with a wound, and state at least 3 components of performing a wound assessment. So, what is a wound? We talk a lot about wound care, but what is a wound exactly? So is this abrasion on this man's leg a wound? What about this surgical site here? Is this considered a wound? How about this lateral hip pressure injury? Is this considered a wound? This lateral ankle, is this a wound? Or how about this plantar aspect of the foot? Would we call this a wound? So let's define what a wound is versus an ulcer, because these terms sometimes are used a bit interchangeably. And I think it's worthy of taking a moment just to clarify from a definition perspective, what is a wound and what is an ulcer? A wound is defined as an injury to the body, as from violence, accident, or surgery that typically involves laceration or breaking of a membrane, such as the skin, and usually damage to underlying tissue. So when we talk about a wound, we're really thinking of like an external cause that causes that break in the skin. So like a surgical wound where we have a scalpel that's causing a break in the skin, a traumatic wound, a puncture wound, those are things that we would typically call wounds. As opposed to an ulcer, the technical definition of an ulcer, and there are a variety of different ulcer definitions out there, but the one we're using for today is a break again in the skin or the mucous membrane with loss of surface tissue, disintegration and necrosis of epithelial tissue, and often pus. So it's a bit vague, but what we're saying is it's a break in the skin with loss of tissue, maybe some necrotic tissue, maybe some, thickened drainage, but we're thinking more of an internal cause for an ulceration. So when we say a diabetic ulcer, it implies that there's an internal problem that's causing this break in the skin. So for example, diabetic ulcer would be maybe structural changes of the foot or sensory neuropathy, maybe some blood flow issues. These are all internal factors that are causing the external break in the skin. Or a venous ulcer, same kind of concept. We have problems with the venous system, with congestion of the venous, with venous hypertension distally in the leg, and that internal problem with the vein causes the external disruption of the skin. So that's how we would define a wound versus an ulcer, external versus internal causative factors. So for the remainder of this presentation, I might just use the word wound to identify wound versus ulcer. I will use both of those terms, but when I say how do wounds heal, I'm saying how do wounds and ulcerations heal. So we'll use the term wound oftentimes interchangeably for those two terms, wound and ulcer. So wounds heal either by what's called primary intention or secondary intention. So primary intention is where you have the wound edges approximated and held together by sutures or staples or a skin adhesive. So those are what we would think of as those surgical site wounds. So again, this total knee replacement patient that had an incision, they did the surgery, they approximated everything, that's closure by primary intention. This also might be something where we would have a delayed primary closure, where a patient undergoes a surgical procedure and then they leave that surgery site open only to come back and close it at a later date, maybe 7 days or so later. Very frequently, if this does happen, this is because of infection at the surgical site, maybe like a perforated bowel, an exploratory laparotomy surgery. They might want to leave that surgery site open to allow the infection to improve somewhat and then come back and surgically close that wound. So that would be called delayed primary closure. And then dehiscence is a term that we use when there is a separation of a portion or all of that surgically closed wound. So now something that was closed by primary intention pops open a little bit. Maybe it's just the skin layer, the skin and down into the subcutaneous tissue, but you do have a separation of a portion or all of the incision. The second way that wounds can close is what's called secondary intention. So healing by secondary intention is where the wound edges are not approximated together or pulled together like they are in primary intention. And the wound is allowed to close by contracting together on its own and growing in of new tissue to fill in that defect. So an example of this would be if a surgical site is left open to close on its own. Maybe an example would be something like a cyst excision that's 6 centimeters in diameter, and approximating those wound edges would put it under too much tension, that they would allow that wound to be able to close on its own, healing from the inside out. And that would be a surgical site wound that's left to close by secondary intention. Again, that filling in of that tissue from the inside out. I describe it to my patients like a pothole, filling in a pothole from the inside out with that new tissue that's healing by secondary intention. Again, infected surgical sites might be left to close by secondary intention. And then ulceration. So we looked at this photo earlier of this diabetic foot ulcer. And this wound would never be closed surgically, maybe a skin graft, but most likely it would be left to close by secondary intention, where that healthy tissue grows in and then the skin grows over the top. So now let's get into the phases of actual wound healing that occur. We're going to talk about normal wound healing, and then we'll move into why wounds don't heal in these orderly phases. So the phases of wound healing, if you look in the literature, it's usually broken into these three well-identified phases of wound healing. You have this inflammatory phase, the proliferative phase, and then this maturation or remodeling phase of wound healing. And this timeline here has some, leeway to it, but in general, if a wound is going to progress from initial injury all the way through to closure and maturation, they say that this timeline goes from day 0 of initial wounding all the way up to about 2 years. And these phases fall into that timeline. So this inflammatory phase is usually day 0 of initial wounding, all the way through to about day 5 is when the inflammatory phase of wound healing is happening. The next phase is proliferative phase, is from about day 3 or 4 to about week 2 or 3 of the process. And then the remodeling phase kicks in from about week 2 all the way through to 2 years post-injury. And so there is some overlap between these phases, as you can see on this graph. We're going to go through and talk through these phases, how they actually look, what's happening during each of these phases, and the cells involved. So let's look at the inflammatory phase. So the inflammatory phase, the very first phase of wound healing. So if you think of this surgical site wound here at the top of the screen, or this lower leg wound, this was actually a traumatic wound from one of my patients that had a golf cart that flipped over and fell on his leg. These wounds are both in the inflammatory phase of healing. So what do we see happening during this phase? So initially we have hemostasis. The bleeding has to be stopped somehow. So hemostasis, which occurs through vasoconstriction initially, followed by vasodilation. So the blood vessels tighten up to try to stop the blood flow, and then they relax and they dilate to allow the cells to come in and move through the healing process. We have formation of a clot through platelet aggregation. It helps to clot off those blood vessels and form a clot within that wound base occasionally, and that helps to stop that bleeding. You see these very characteristic signs, these Latin terms that we've seen: rubor, dolor, tumor, and calor, or redness, pain, swelling, and heat that we see in the inflammatory phase. These are normal parts of the inflammatory phase of healing, and you can see some of those even demonstrated in these photos that we see. We see a little bit of that redness on the surrounding skin. We see that taut, shiny skin, which is indicative of some swelling. If we were to ask the patient if it hurts, they might say yes, if they have good sensation, and it might feel warm, which is very frequently confused with signs of infection, of course, right? But in these first 5 days post-injury, this is a normal part of the inflammation phase of wound healing. The primary cells involved in this phase are going to be your platelets, as we mentioned, that help form that clot, the neutrophils, which also are involved with the clotting process, and phagocytosis, which is the ingestion of debris and bacteria to help fight infection and to help create a clean wound environment. Macrophages, which are also involved in phagocytosis, and then the mast cells, which can mediate this entire inflammatory process. This is not an all-inclusive list of all of the cells involved in the inflammatory phase or in the subsequent phases. These are just some of those primary cells that are involved for the essential cells that are needed for these phases. Moving on into the proliferative phase of wound healing. Again, we're thinking about day 3 or 4 if you're talking about normal wound healing, all the way up to about week 2 or 3 of the process. So what's happening in the proliferative phase? We get deposition of type 1 collagen into the wound, which is where we start to see that ingrowth of that healthy red scar tissue, which is called granulation tissue. So granulation tissue is just scar tissue that we can see in the wound itself. So when you think of a scar, we all have scars from some sort of past injury or surgery. Below that was granulation tissue formation. If it was an open wound, that grew to fill in that tissue defect. And it's primarily type 1 collagen that is deposited to grow that healthy tissue. There's also formation of this extracellular matrix. It's a beautifully complex matrix that helps to support the cells that come in for healing, and they promote growth factor deposition. The growth factors are kind of the things that help to keep that process moving along. So platelet-derived growth factor, there's lots of different growth factors that are out there that are deposited that help to stimulate that cellular activity and healing response. The extracellular matrix helps to support those cells and those growth factors. There's angiogenesis, which is new blood vessels that are now starting to grow into that granulation tissue, grow into that scar tissue defect to help fill in that tissue from the inside out. So angiogenesis, that's what gives this tissue this nice healthy red color, is because it's filled with new blood vessels that are growing into that tissue. The primary cells involved in this phase are going to be fibroblasts. They're the ones doing most of the collagen formation in the wound that's depositing that type 1 collagen. And they're also helping to contract that wound together from the edges in towards the middle. Those are called myofibroblasts. Myo meaning muscle. They're helping to pull those wound edges together. The macrophages are involved as mediators of this proliferative phase, and they're involved again with that phagocytosis, or the ingestion of bacteria and debris. The endothelial cells are ones that are involved with angiogenesis. So that new blood vessel that's forming in that tissue is because the endothelial cells are active in doing that work. Platelets are helping to deposit growth factors in this phase. The epithelial cells are the new skin cells that are growing from the edges over that healthy red tissue. And if you look at this lower right photo, that pink edge right along the side of that healthy red granulation tissue, you can kind of see that thin pink edge. That's the new epithelial cells. You can easily identify that in this dark-skinned patient, that this new skin that's growing, that light pink color, those are those epithelial cells starting to migrate across that healthy red tissue. And then the mast cells help to support cellular proliferation. Again, they help to mediate this process. They're so important to this phase of wound healing. And then finally, we move into the remodeling phase, that kind of starting from the 2 to 3 week point, going all the way through to the 2-year point post-injury. So what's happening in the remodeling phase? Well, we get changes to the scar that are happening under the skin. So the skin finally finishes growing over that wound, and the scar starts to change underneath the skin. I oftentimes tell my patients when I'm doing education with them, it's like taking a bowl of cooked spaghetti that's all mishmashy and it's all jumbled together, and it slowly remodels over time like dense, like duct tape. So it's stronger and it's more solid, and it's less likely to be pulled apart as duct tape as opposed to this mishmash bowl of spaghetti. So changes to the scar underneath the skin. The type 1 collagen is replaced by type 3 collagen. So you get collagen breakdown, collagen synthesis, you get collagen remodeling because the collagen fibers are reorganizing themselves again into more of that like duct tape type of consistency, so it's not easily pulled apart. But this takes up to 2 years to complete. And so you can imagine in a patient that has some sort of wound or ulceration, that area is at risk for re-injury. When the cells first come across and they close that wound, that tensile strength is not great. It's probably, I think, in the realm of 20-30%, if I remember from the literature. It's very, very weak in how those collagen fibers are organized to be able to maintain that tensile strength. And so it takes up to 2 years to maximize at 80%. And so that area needs to be protected and watched. And especially, let's just say somebody with a diabetic foot ulcer that's walking on it, How do we protect that newly closed area so that you don't re-injure and re-ulcerate? You get nerve fibers that start to grow into that tissue. So that granulation tissue we showed on the previous slide with lots of blood vessels in it does not have lots of nerve endings in it. So it oftentimes doesn't hurt. Like if you had to debride or cut, you don't get a lot of pain oftentimes in that granulation tissue because there's not a lot of nerve fibers in that tissue itself. There might be a lot of nerve fibers around it, but usually not in that tissue until we hit this remodeling phase and those nerve fibers can grow in. The cells involved are similar as the cells involved in the proliferative phase, those fibroblasts, the myofibroblasts, the endothelial cells, the epithelial cells, but those cell numbers start to decrease as we move forward through that 2 years of remodeling. Okay, so we've just talked about the phases of normal wound healing, right? So we all expect our wounds to heal normally, right? Well, what happens when we get this wound showing up in our clinic or in our hospital, in your practice setting, whether you're in long-term care or in a skilled nursing facility or in home health? What do you do when you see this wound? Or, what do we do when we get this wound that shows up? Are these wounds healing in those orderly, timely, normal wound healing phases? Or maybe this wound, what happens when this one shows up in your practice setting and you're the wound care specialist and you're the one asked to intervene? So what do? Well, maybe you scream for help, I'm not sure, but there's lots of people that should be able to help you on your team if you're newer in this setting, not just wound care, but other clinicians, other nutritionists and physicians that can help with this. But this is the point of this education, is to equip you so that you know what to do when these wounds come into your practice setting. So let's talk about acute versus chronic, because acute wounds progress beautifully through these typical wound healing phases that we just talked about, and they often close within about 6 weeks of time. These wounds very frequently don't need our wound care specialist intervention. Maybe they're happening on patients that are younger or less comorbidities. Maybe the site is more amenable to healing, maybe on the abdomen or on your arm. So those areas maybe are easier to heal, or again, the patient's just in a better situation that those acute wounds can heal without a problem. But chronic wounds, those are the ones that oftentimes need our help as wound care specialists. And that's what this is helping to equip you to be better at handling these wounds. So chronic wounds have this delayed wound healing. They're often stuck in this inflammatory phase of healing. And so they just can't move forward into that proliferative phase. And that's where we have all sorts of tricks and tips and treatments to help move that wound into the proliferative phase of healing. Many factors may contribute to this healing delay. Somebody's age, their nutritional status, their medical comorbidities, their social support, their financial situation. Lots of factors. That's not an all-inclusive list, but those are some of the real common factors that we see that cause acute wounds to become more chronic. And again, they need our help to move them into the next healing phase. All right, so those are the wound healing phases in a hot second. Hopefully that was clear to you. And if you have any questions, feel free to throw anything into the chat function and either Joe will answer it or he can bring it to my attention and I can address it to the entire group. But we're gonna move forward now into the actual evaluation of a patient with a wound. And this will cover the majority of the remainder of our presentation. And we'll end our presentation today with a couple of case studies to try to pull it all together. So, evaluation of a patient with a wound. I'm going to start by giving you some of my own little tidbits of advice for whatever it's worth. I've been doing wound care for about 25 years and I've learned a lot of what to do and what not to do. And so I just want to give you a few things that I can think of when it comes to a really good wound care clinician and what sets them apart from maybe just more introductory level clinician, or maybe somebody that doesn't have any wound care knowledge. So what kinds of things make us really excellent at what we do? So for me, this is my practice pattern. I zoom out on the patient before I zoom into the wound. That it means to me, I'm going to assess the patient before I assess the wound. And we're going to get into in these next slides, what does that mean to assess the patient? I'm going to go through medical, surgical, social history, medications, nutritional status, all sorts of different questions I have for the patient before I take that dressing off and look at the wound. For me, if I look at the wound first, I will oftentimes not remember to ask all the right questions, or get kind of caught up in the wound itself and forget to ask all of the things as to what led them to the place of having this wound. So assess the patient before you assess the wound. Take an excellent history yourself, even if somebody else already did. The person that already took the history might not have any wound care experience or knowledge. I'm thinking maybe in the acute care setting or in a long-term care facility. Maybe somebody else who did that initial intake doesn't have the wound care knowledge that you do. And so they might not have asked all of the probing questions, or maybe the patient gives a different answer and you want to just verify that information. And so take an excellent history yourself. Don't rely just on what the chart provides you in terms of the information for that patient and their history. Be an excellent investigator. I think some of the best wound care clinicians I know think of themselves as like a private investigator. Like, I'm here to solve a mystery. I'm here to try to figure out why this wound happened, what I can do to help it to get better as fast as possible, and reduce the risk of it coming back again. So ask the right questions, listen to what they tell you, and listen attentively so that you can ask good follow-up questions. So sometimes a patient will tell me, the wound has been present for a week. And I look at the wound and I think, this wound has been present for longer than 1 week. This looks like it's been present for at least a month based on the size or the necrosis or whatever. And so I ask a lot of questions, kind of really verifying, their story and really digging into like, okay, well, you noticed it a week ago, but really, did you notice that there was any drainage on your sock like a month ago, anything at all? So I do ask good questions, ask follow-up questions, be a great listener. And then does their story align with the examination that you're doing on that patient? So be a great listener. And then this last question is not sensitive, but it is just a bit of a probing question for you all to ask yourself. But are you going to treat just what you see, or are you going to actually investigate the root cause? So in a group this size with all sorts of different experiences, there are people that will come into the room and they'll assess the wound and they'll put an appropriate dressing on and then move on. And if that's the type of clinician that you are, okay, that's fine. But do we want to turn into clinicians that maybe start to really understand why this wound happened so that we can educate our patients on how to prevent this from happening again, and we can apply the most appropriate interventions to get that wound to improve as quickly as possible? So it's just a self-examination question, like, do I want to be that kind of clinician that really wants to understand what's happening with that wound? And I understand, again, in a group like this, we have people from maybe nursing assistants that are involved more in just addressing change at this time, but you can be involved more in asking good questions of your patients, maybe turning schedules or seating and positioning things that can help to enhance the healing even from your level as a nursing assistant, all the way up through, you've got nurses and therapists and physicians and mid-level providers. We all have the opportunity to intervene and to ask questions to help get at the root cause of why this wound is there and how we can help it to improve. Okay. So we're going to start with the whole patient. So we're zoomed way out now at this point. We're going to start with asking the history of the wound. So this is all my patient. When I'm sitting down and I'm taking an interview with a patient, I'm gathering the history from the patient. These next 3 or 4 slides are all the questions I'm asking, question. And in my evaluation, this probably encompasses at least 50 to 75% of the time of my evaluation. By the time I get to assessing the wound itself, I very frequently already understand what I'm most likely going to look at because I've taken such a detailed history from the patient and I've really understood where they're coming from before I've even lifted that dressing. So I'm going to get a history of the wound. How long has it been present? Has it been getting better? Has it been staying the same? Has it been worsening over that period of time? What's the cause of the wound? What do they identify as what caused that wound to start? Did they step on something? Did they just kind of start on its own? Did they scratch themselves? What is there, in their words, what caused that wound? Have they had any history of similar wounds? And if so, how did it heal? How long did it take to heal? What kind of treatments were provided to be able to help it to heal? How long ago did you have that wound? And any treatments currently or previously that have been done, antibiotics, dressings, compression, offloading, other wound care centers, what has been done to be able to either treat this current wound or wounds that you've had in the past? Any tests that have been done. So I'm asking the patient, have you had any biopsies? Especially if they're outside of our healthcare system, have you had a culture, any kind of imaging, lab work? What kind of things have you had done and from what kind of provider? Pain levels, so important, especially with wounds that don't necessarily fit a normal category. For example, some of these atypical wounds, they may really be very different with regards to some of their pain, but this gives me some insight as to what caused this wound, is understanding their pain. Is there pain at night? Do they have pain with walking? What type of positions make their pain better, worse, or keep it the same? What type of pain do they have? Is it shooting, throbbing, pain? Is it stinging? Is it burning? How would they describe their pain? Is it intermittent? Is it constant? Does it happen 3 times a day? Does it happen, how often is it happening? Is it getting better, worse, staying the same? Describe to me what's going on with your pain. Sometimes the pain doesn't correlate with what I'm seeing with the wound, meaning I've had some wounds that look like a diabetic foot ulcer that are actually not, and their pain didn't line up with the fact a diabetic foot ulcer is oftentimes not painful, but I've seen patients that have a very painful wound and it turned out to be a cancerous type of wound. And so we're looking at that pain to help guide us. Again, we're the investigators and we're trying to hone in on what's causing this wound. Medical and surgical history, so important for us to gather this information, a full review of their known medical history. These ones listed here are the common ones seen in the chronic wound care environment: diabetes, peripheral vascular disease, coronary artery disease, congestive heart failure, hypertension, chronic kidney disease, on or off hemodialysis, maybe peritoneal dialysis, but most commonly hemodialysis. Are they obese? Do they have venous disease? And if they have signs of venous disease, have they ever been diagnosed with venous disease, which would be done typically through a venous reflux study and consultation with a vascular surgeon most frequently. So what is their medical history? Because that absolutely contributes to their healing. Do they have any known autoimmune disorders? Rheumatoid arthritis, Crohn's, lupus, scleroderma? What kinds of autoimmune things do they have? Because these will absolutely impact healing, whether it makes them a bit more prone to infection or the medication is going to slow down their healing response. But we need to know, do they have any autoimmune diseases? And then do they have any known history of cancer? We're always thinking of cancer in the back of our mind when we're doing wound care assessments, because it can sometimes be that sneaky one that comes in and you think it's a venous ulcer and actually it's some sort of melanoma or something like that. So do they have any known history of cancer? Have they been to see their primary care physician or their medical team recently? This is a question I ask my patients all the time. For example, if a patient has diabetes, when was the last time they saw their endocrinologist, if they have one? And if so, when was the last time they had a glycohemoglobin drawn so I can see what their blood glucose control has been over the last 3 to 6 months? So have they actually seen their physicians that are involved in their care? Do they have a podiatrist if they're diabetic? And if not, can I help connect them with a podiatrist so that they can have ongoing foot care to take care of those thickened nails, to do those foot checks, to help them get their diabetic shoe wear? So asking kind of the primary care and then their other physicians, if they've seen those, and then if they haven't, if they don't have those people on their team, do they need them on their team? These other specialties are common specialties that we see in the wound care world, infectious disease and vascular and plastics and rheumatology. They are such key players, cardiology, key players to our team. I can't function in a silo. I need all these people to be able to help manage their medical situation, because otherwise I'm not going to be successful at either getting their wound to close or helping to keep it closed long term. What's their surgical history? The things that we're really looking at in our that are common surgeries in our chronic wound care patients are revascularization procedures, whether it's cardiac or lower extremity revascularizations, prior amputations, endovenous vein procedures, or surgical debridements. All of these things factor in to how their wound may progress towards closure. Medication review. Some medications do slow or inhibit wound healing, so we need to know what kind of medications they're on. And then, are they taking all of their medications? So glucose control is really big in our diabetic population. And what is their A1C for that, again, that glucose control over the past few months? Diuretics are a big one. Again, for those lower extremity edema patients, are they on diuretics? And if they're not on diuretics, should they be on diuretics? There have been several patients that are not on a diuretic, and I've talked to their primary care physician and they've started them on a diuretic, which is so helpful to help control that lower extremity edema, oftentimes in combination with compression. So are they on a diuretic, and then are they taking their diuretic the way that they're supposed to be? We've all seen those patients that have been prescribed, BID Lasix, and they're not taking it that way because it interferes with their ability to be able to go out and do grocery shopping and that type of thing. And so the urinary frequency is for sure a problem with those patients. And then antibiotics. Have they gone through a course of antibiotics? Yes or no? Have they completed that course? Nutritional history is so huge in the chronic wound care population. What is their current nutritional intake? This is a question I ask of all of my patients. How many meals a day do you eat? I eat 2 meals plus snacks. Okay, are they full-size meals or are they small meals? How much of their plate do they take up? As you get older, oftentimes you'll see that food intake quantity and quality sometimes decline. So you see them eating less food, and sometimes it starts turning into the type of food becomes an issue. So instead of cooking from scratch, maybe now they're using more prepared foods, frozen foods, fast foods, and we all know the nutritional content of those foods is reduced. And so what type of food are they eating as well? And then weight changes. Have they had an unintentional weight gain? Have they had an unintentional weight loss? An unintentional weight gain, we start thinking of stuff like congestive heart failure and fluid overload sometimes. Unintentional weight loss, we think of nutritional issues or maybe even cancer-related issues. And so we do ask about weight gain, weight loss. We do monitor weights in our clinic, in our practice setting, because we see people oftentimes weekly or so on. And so we can check their weight and track that. But it's definitely a question that I ask. Social history. This is a big one, and I have a lot of little bitty bullet points on this because I feel like this is so important. Maybe not as much in the long-term care setting, but definitely in home health, in the outpatient wound care setting, in the inpatient wound care setting, in a skilled nursing facility setting where you're trying to transition the patient to home. So these are such important questions that you want to set your patient up for success, for closure and sustaining closure. So what is their living situation? Are they living in a home? Are they in a facility? Are they homeless? Which we've definitely seen our fair share of homeless patients. And that brings a whole different set of challenges when you don't have a home to be able to do dressing changes in. So what is their living situation? Do they live alone, or do they have family or a caregiver involved? Who can help? Who's willing to help? Just because you have a spouse doesn't mean that they're willing to help, right? So who's willing to be able to help do dressings and offloading and compression and position changes and foot care? We need to know these types of things. Is the patient really capable of caring for themselves in the ways in which they need? So an example of this, we see this very frequently in my setting, is somebody's maybe in their 70s and they have lower extremity edema and they need to wear compression every day, but they live by themselves and they can't reach their feet. And so how do you address that when they have a level of need, but they can't actually fill that? It's a really, really complex with a scenario with no great solution, honestly, in the outpatient setting very frequently, but are they capable of doing the care for themselves that they need? They always think they are, but really, are they capable of it? What's the cleanliness of their home? Are they walking barefoot on dirty floors? Do they have pets with pet hair in their dressings? So what's their cleanliness of their home? Current or previous tobacco, alcohol, drug use definitely impacts our healing. Transportation barriers, if you're in the outpatient setting, can they actually get to their appointments? What are their daily patterns that they do every day? Are they dependently positioning their legs day and night? They sleep in a recliner because they have COPD and they can't actually sleep laying flat. What's their mobility status? Are they an unlimited ambulator? Do they walk to the train station for work with their diabetic foot wound? Or are they a limited ambulator and they can't get around all that much? So how much do they walk? Their falls, that impacts what I'm going to do with them, any assisted devices that they use. So what are those daily patterns? How much do they lay down? How much do they sit up? How much do they walk? I'm always asking about that, not just because I'm a physical therapist, but because I think it has a huge impact on them in terms of their healing. Support surfaces, do they have what they need? Do they need you to help them get a support service, maybe a wheelchair cushion or a bed overlay? And then their financial history. Are they insured? If they're insured, are they underinsured? Do they have the type of coverage that they need? Maybe for DME supplies, for compression stockings, for diabetic shoes, for dressings, for doing dressing changes at home. Some insurances don't have great DME coverage. DME is durable medical equipment. So they might not have great coverage for home dressing supplies. For current or for the future. So what's their financial? And if they don't have great insurance, do they have the financial means to be able to pay for something out of pocket? A common situation we run into is we can get compression stockings for our patients that have a venous leg ulcer when they have an open wound, but they have to know when that wound is closed and they need replacement stockings that they're probably going to have to pay for it out of pocket. And that's really unfortunate that that's the way that our system is set up. But do they have the financial means to be able to pay for that when that time comes? Okay, so that's my big ask of my patients of getting that history from them. So we've zoomed way out, we've asked all those questions, we've tried to gather a full understanding of what's going on with that patient. Now we're going to start to zoom in on that wound itself, because now we understand, okay, this is what's going on with the patient. I have a full grasp of their situation. Now I'm going to start zooming in on that wound. So what are the common ulcer types or wound types we see in the chronic wound care patient? So this list of 7 is not exhaustive, but it is the most common ones that we see. We see arterial ulcers. So this black eschar that forms on the toes, usually in response to peripheral vascular disease. So arterial disease, limited arterial flow, getting down to the foot. That's why we ask about like lower extremity bypasses or angioplasties that they've had done, ways to open up that arterial flow. Venous ulcers, I showed you that photo earlier of this patient with a classic venous ulcer on the inside of the ankle. Diabetic ulcers on the plantar aspect of the foot, most typically, but they can be in other areas of the foot, most commonly plantar. Pressure injuries, the sacral pressure injury right here that we can see. Traumatic wounds, that man with the scraped lateral leg. Surgical sites, this is a great picture of a partially dehisced exploratory laparotomy abdominal wound. So you see that separation in some areas, but closure in others. And then atypical wounds, wounds that just don't really meet any criteria of those other ones. It's not arterial, it's not venous. And so these atypical ones that we oftentimes need to get a biopsy to help us figure out, in addition to labs and that type of thing, but ways to be able to help us figure out what the cause of this wound is. Okay, we're zooming in, we're getting into wound assessment. So this is going to be the nuts and bolts of how do I actually assess this wound. So I'm going to start with the size. We're going to use the sacral pressure injury as an example. So length, width, depth. These are the things I want to document when I'm doing my wound assessment. Length, this is somewhat facility dependent. I've seen it done both ways where the longest length is the longest measurement is your length. I've also seen head to toe be your length. So check with your facility, but the length in this situation is going to be from this skin edge to this skin edge here, like 12 to 6 o'clock. And that's going to be documented as our length. The width is going to be 90 degrees perpendicular to that. So this arrow represents the width of the wound. So let's just say the length was 5.3 centimeters. The width is 2.7 centimeters. And now I'm going to measure the depth, which I can't capture with an arrow, but I'm going to stick that cotton tip applicator into that wound gently. And I'm going to find the deepest aspect of that wound and take that to the level of the skin. So I'm going to pull that cotton tip applicator out, holding it with my fingers. And I'm going to say, oh, this depth is 4.2 centimeters deep. Maybe in a different area, it's only 3 centimeters deep, but I want to measure the greatest depth. So that's what I'm measuring in this wound, is the greatest depth. The clock method, which we'll get into here in the next slide with tunneling and undermining, is important to know because we think of the patient's wound as being on a clock. So 12 o'clock is going to be towards the head, 6 o'clock towards the foot, and the 9 and 3 respectively, as they would be on a clock. So when we get into actually assessing for tunneling and undermining, we want to think about that clock. It's 12 o'clock being the head, 6 o'clock being towards the foot. And we're going to gently probe that wound, and we're going to assess for tunneling and undermining. So a tunnel would be this narrow sinus tract, as we see down here towards the bottom of this photo, that's within the wound bed. So as I'm sticking my cotton tip applicator, I notice a small little tunnel, and I'm going to stick that in until I meet some firm resistance. I'll pull that out and measure that, and I'll be able to document that there's maybe a 3.5 centimeter tunnel noted at 4 o'clock on a skin clock. So I can accurately note where that tunnel is happening. And then undermining tends to be more of a broader area of tissue loss underneath the surface of the skin. And this might happen in reaction to shearing forces or friction forces. In a pressure injury is probably the most common time that we see undermining. So because of those shearing forces, we might see greater tissue loss under the surface of the skin. So we would document that as being 2.5 centimeters of undermining from 9 o'clock to 3 o'clock on a skin clock, or something along those lines where we probe the deepest area of that and we document that. I might have multiple areas of tunneling or undermining in my wound that I'm documenting. Maybe I have undermining of 3 centimeters from 3 o'clock to 6 o'clock. I have undermining of 5 centimeters from 6 o'clock to 9 o'clock. So you can document multiple areas of tunneling and undermining. We want to make sure in our wound assessment that we're documenting the tissue types that we're seeing in the wound. So if I'm documenting that healthy red tissue as granulation tissue, it might be pink, it might be red. So I might say it's red granulation tissue or pink granulation tissue. We sometimes use other descriptors like glossy or friable, meaning fragile. So the granulation tissue we can see here in this lower right wound, this healthy red tissue here that's growing in. We want to document the necrotic tissue as well, yellow slough, black eschar. So that's the dead tissue in the wound. And we want to document that as well. And we can see that here in this yellow in the top photo here, that we would document this as some yellow necrosis or yellow slough. And we often use percentages. So maybe in this top photo, we would say this is 95% yellow slough, 5% pink granulation tissue underneath. You know, you can assess it and determine what you think is the right percentage, but we document it in percentages because most wounds are a mixture of different tissue types. We may have structural involvement like tendon or bone in the wound itself, as we can see here in this lower right photo, and we definitely want to document that as well. We might see muscle exposure, we might see vessel exposure, veins, or heaven forbid, an artery exposed in the wound bed. We definitely want to document that. And then do we see any signs of new skin growing from the edges? So that's that epithelialization that we start to see along this wound edge here, this pink tissue that's growing over that healthy red tissue. We want to make sure that we include the wound exudate or the drainage that's coming from this wound. And this is the descriptors that we often use to describe that drainage. We can describe it as being serous, which is what you would think of in a blister, that clear, light yellow, almost like urine colored drainage. Again, think of a blister and that's serous drainage. And then serous drainage that's slightly blood tinged would be called serosanguinous. So that thin pink tinged serous drainage. Sanguinous would be bloody drainage that we're seeing on that dressing as we're taking it off. The wound might not be actively bleeding, but we might see bloody drainage. Purulent would be that thick yellow, more pus-like drainage. Green or blue tinge could be indicative of bacteria that's in the wound, usually Pseudomonas. The quantity of exudate we want to document, how much is there, minimal, moderate, heavy, copious, presence or absence of odor. All of those things are good to document. Peri-wound assessment, what's happening on my surrounding skin? Is there swelling? We want to document swelling, and maybe we're taking circumferential measurements at the foot and the ankle and the calf. Is it pitting or non-pitting edema, and documenting that? What's the color of the surrounding skin? Is it red? Is it pale? Is it cyanotic or bluish? Is the skin intact? Is it weeping? Is it fragile, rashy, dry, moist? What are we seeing? What's the temperature of the surrounding skin? Normal, hot, cool, cold. When we palpate it, when we push on it, what does it feel like? Normal, firm, fluctuant, feels kind of like a squishy ball, like when we push on it. Fibrotic, hard and woody in feeling. And then I do want to note dependent rubor versus cellulitis or erythema. We see this confused very frequently. Like in this photo here on the right, this is actually not cellulitis or erythema. This is dependent rubor, meaning when the leg's in the dependent position, it's red like this. And this in this patient was because of chronic inflammation from leg edema. But when I elevate his leg for 20, 30 seconds, that redness fades out. And that's how we can differentiate cellulitis, which doesn't fade with leg elevation, versus dependent rubor, which is an inflammatory response, usually because of prolonged leg edema. So that's a real common thing that we see, that if you just elevate the leg and that redness goes away, it's most likely not an infection. You want to correlate that with lab work and fevers, chills, other systemic signs, but that's a good screening tool. And then a vascular assessment. We can't do lower extremity wounds without a good vascular assessment. So is there pulses? We want to document that. Dorsalis pedis and posterior tibia are the most common ones that we look at. And can you palpate it versus do you need to listen to it with a handheld Doppler? Capillary refill, less or greater than 3 seconds. Normal is, of course, less than 3 seconds. Color, again, what's the color of the tissue? Is it pale? Is it purple or blue? Those would be indicative oftentimes of vascular disease. Hair growth, documentation. Is there hair growth on the toes or the foot or the leg? Absence of hair is oftentimes a sign of vascular disease. Again, temperature assessment. And then the skin appearance. We can see in this photo, the skin is just dry in some areas and moist and kind of sloughy. So we want to document that skin appearance. Okay, things I did not cover today. We're going to do 2 quick case studies before we open it up to questions. So I just want to make sure we are aware, I did not make this an all-inclusive evaluation PowerPoint presentation because there are lots of things we could have covered and didn't, like additional testing, pressure injury staging, pathophysiology of these different wound types, interventions that we can do for these wounds, advanced assessment techniques, support surfaces, diabetic shoes. We could have gone on and on and on, but we have plenty of other ABWM Foundation videos for you to reference if you want more information on these. So let's get into a case study or 2, and then we'll open it up for some questions. So our first case that we have, 63-year-old male admitted to the hospital for a right foot infection, status post-surgical irrigation debridement, now post-op day 2. So what are our zoom out questions that we want to know and gather from the patient and the chart? His medical history is significant for diabetes, peripheral vascular disease, coronary artery disease, hyperlipidemia. His surgical history is significant for an angioplasty of his right leg and a coronary artery bypass graft. His social history is that he's retired. He lives with his wife at home. He's an unlimited ambulator without any assisted device, and he says he has never smoked or drank significantly or any drug use. What he tells you when you ask him about the etiology of the wound is that he noticed blood on his sock 3 days before he was admitted. He eats 2 meals a day plus snacks. His wife kind of cooks a mixture of prepared foods and then cooks from scratch. So think of it. What do you want to investigate further about this patient? He's post-op day 2 of a diabetic foot infection, had surgery for a washout. So what are some things you can think of you'd want to ask? Maybe something like this. Does he walk barefoot? Does he have diabetic shoe wear? Does he do diabetic foot checks? Does he remember stepping on anything sharp? Does he have any history of wounds on his feet? So these are some kind of things that I thought of. There's probably a ton more that we could have asked him, but these are at least a few. Some additional information that would be great to gather on this patient would be some additional lab work. He's in the hospital, so hopefully there's some labs, including like a white blood cell count, an HbA1c, a culture, a biopsy, maybe from surgery, some imaging studies, some vascular studies. And then what other services are involved with the patient, maybe infectious disease, orthopedics, vascular, because he has a known history of peripheral vascular disease. And then a medication review. So here's his wound. So now you're going to do his wound assessment. So what are we looking at here on this wound? Well, we're going to document that we see some granulation tissue here. We see some yellow slough here. Maybe we see this tendon right here. That's a flexor tendon. We can document that he's got dry, cracked skin. That's real common with patients with diabetes because of neuropathy. Callus formation here at the first metatarsal head. So he's got some heavy weight bearing happening here. We want to document his length and his width of this wound, and definitely a depth with a Q-tip. What's the exudate, the color, the odor, the quantity of exudate on the old dressings? And then, of course, our vascular check. He hopefully has had some vascular studies while he's been in the hospital, but what's our vascular assessment? All right, case 2, this is our last one, 89-year-old female living at a skilled nursing facility with a sacral pressure injury. We're zooming out, we're gathering information from her. She's got a medical history of a stroke and high blood pressure, no surgical history. She denies any drug, tobacco, alcohol use. She's a limited indoor ambulator with a walker. She needs some assistance for bed mobility. Her nutritional status is she eats 1 to 2 meals a day and maybe drinks that protein drink that shows up on her tray. So possible more questions we would want to ask. What type of support surfaces is she on currently and has she used in the past? Can she do any kind of wheelchair or bed pressure relief, and how often? What's her sleeping position at night? Is she laying on her wound, and does she change positions at all? What's her continence status? Bowel bladder continence is really important to know in these patients with sacral pressure injuries. And does she have any history of wounds in the area? Further information would be nice to get, some labs, some imaging, maybe medication review. So here's her wound. So we're going to do our wound and peri-wound assessment. We've got some granulation tissue in the wound base here. We do have exposed bone in the base as well, unfortunately. We've got some yellow and black necrosis here on the surrounding skin, so we want to document that. That peri-wound is what we would call mottled or dusky, and we would document if there's blanchable versus non-blanchable erythema. Again, something we didn't get into in this talk, but just document, what do you see? Red, purple, kind of splotchy peri-wound. What kind of drainage is there? Color, amount, odor, what are we seeing on that old dressing? Length, we would document as being about from here to here, I would probably capture, and then width is 90-degree perpendicular to that. And then depth, again, we're sticking that cotton tip applicator straight into that wound, and then we assess it for tunneling or undermining as well. So in summary, what did we look at? Wound versus ulcer, primary versus secondary intention healing, acute versus chronic wounds, the 3 different phases, that inflammatory, proliferative, remodeling phase of healing. We're going to zoom out before we zoom in on that patient and really assess the whole patient before we look at their wound. We're going to do a really great wound and peri-wound assessment, as we talked about. And then we looked at some case studies. So on that note, I will say thank you for everyone's attendance, and we can open it up for questions. I'm happy to stay here. I know we cut it right to 4 o'clock, but if any of you want to stay on and ask some questions, I'm happy to answer.
Dawn, thanks so much. That was an excellent presentation. And we do have several questions that have come in. First one, Robert asked about photo documentation when you're seeing wounds. Do you typically photo document? Does your facility allow it? Or, what are concerns about that with legality?
Yeah, it's a great question. So it's very facility dependent. I would say you need to check with your facilities policy with regards to where they stand on that from a legal perspective. In our practice setting, we do photo document in the outpatient setting, but we do not, as a wound care service, photo document on inpatient. And that has to do with how our organization has chosen to handle that from a legal perspective, but it's very organizationally specific.
Okay, very good. Okay, wanted to ask on your first presentation there, what about maceration as part of that wound? Was that something that you visualized there?
Yeah, so maceration, so that's great. So that's kind of falls under that moist, that you know, too much moisture on the surrounding skin. So maceration usually has that kind of white, like you've soaked your hands in dishwater for too long, that white appearance. And so yes, definitely it's a good point, documenting that maceration, that whitish kind of too wet appearance to the surrounding skin.
Okay. Question here, is a lesion a type of wound or an ulcer? When you use the term lesion.
A lesion. I'd have to look up the definition of what a lesion is. Just right now, I would think of a lesion as being an external cause, like some kind of external, etiology. So I would think of that as more of a wound, but I would have to look up the exact definition of lesion. I don't think lesion is usually a term we often use in the wound care world, at least not in my practice setting. Joe, I don't know if you have any thoughts around that, but.
Right. No, I would agree. Yeah. It's something generally a little more specific. It's something going on internally that is being dealt with. So, okay. When measuring length and width, do you include the peri-wound skin changes or areas of undermining, or just the obvious open area?
Oh, that's a great question. So just the obvious open area. So intact skin to intact skin is where you're measuring the length and the width. And then I may actually document if there are skin changes on the surrounding skin, I may take a measurement of that and document that. So I might say that there is peri-wound, modeling or purple or red discoloration that extends 7 centimeters at 12 o'clock on the peri-wound. So a real nice way to specifically document that, if you want to get more detailed, is to include an actual objective measurement of that. Or let's just say there's redness, there's actual erythema that extends around the wound completely circumferentially 2 centimeters. I can document that. I'll say, erythema extends 2 centimeters on the peri-wound in a halo fashion, or completely, around the entire wound. So, so it's nice to add that objective measurement. That's 201. That's
Okay.
The 101 is documented that it's there.
Okay, in your practice, I know this changes state to state with state laws, but in your practice, do you perform sharp debridement?
I do perform sharp debridement as a physical therapist in the state of Illinois. It's under my Practice Act to perform sharp debridement of devitalized tissue is the definition of sharp debridement, versus excisional debridement, which is removal of viable tissue, and that needs to be done by a qualified professional for that, and that's out of my Practice Act. But debridement of necrotic tissue, which is sharp debridement, yes, I do.
Okay, great. Okay, do you have any suggestions for allied health care providers, not nursing, who want to become more involved with wound care professionally?
Do I have recommendations for non-nursing allied health professionals and how to become more involved with wound care? Is that the question? Oh, correct. Yes. Well, absolutely. I mean, there's so many ways to become involved. There's lots of different conferences to be able to attend that can provide networking opportunities. That's a great way to get educational information. That's a great way to network with your peers and your colleagues that have a mutual love and passion for wound care. I think that if there's nobody within your organization that has the love and passion that you do, networking with people in your local area. Sometimes I've found like Facebook groups or, just different social media platforms. There's ways to be able to connect in through there. Sometimes there's chapters of wound care professionals that are willing to meet quarterly. I've heard of that. There's some great publications out there to be able to subscribe to that can help you with enhancing your knowledge and, again, networking with different people. But having a mentor, I think, is invaluable if you are early on in your career with wound care, just to help give you that guidance and give you some of that training, some hands-on, like on-site actual mentoring is invaluable. And then definitely branching out into, local networks and then national networks through different conferences. So lots of great ways to get involved.
Great, thanks. Follow up to a previous question about the lesion. The person commented that a course they recently took said that a lesion was an old terminology and that also was a new term. At least that's what she learned from that course. Okay. Would you add hypergranulation on your wound assessment?
Yeah, definitely. I mean, hypergranulation tissue. Again, there's so much I could have covered in this topic, in this lecture, that could not be included for the sake of time. But hypergranulation tissue, meaning, yes, it's growing up higher than the level of the skin, very frequently in response to negative pressure wound therapy, but not always. And so, yes, documenting hypergranulation tissue, and then, how are you going to treat that would be great too, but yes.
Okay. And we'll just catch a couple more here and then we'll try to get the others offline. I know we're running short on time, but regarding documentation, do you also identify wounds which may be unavoidable or in terminal stage of illness or related to an acute or chronic skin failure?
Yeah. And I think that that's a topic that's probably best covered if there's like a good pressure injury, webinar just on that, because there's so much to that. But yes, absolutely. Those Kennedy terminal ulcers on patients that are end of life, the unavoidable pressure injuries. Yeah, I feel like that's a whole webinar all in itself, is unpacking all of the pressure injury stuff for sure. Yes.
All right. Okay, and last question here. You mentioned asking the patient if they're taking their prescribed medications. If they're not, what is your next step? Do you recommend them contacting their physician, or do you reach out to the physician with that info, particularly if the medication is important to their healing?
Yeah, great question. So, I handle that tactfully with the patient because I'm trying to gain their trust, and I don't want them to think that I am always just turning around and tattling on them to their physician. So I try to understand why they're not taking that medication. So an example of like a diuretic, like we gave the example, is, why are you not taking that diuretic? And, I'm not taking it because it means I can't leave my house. Okay, well, have you ever talked to your doctor about timing your diuretics a little bit differently so that it doesn't interfere with your ability to go grocery shopping or that kind of thing? So I try to handle it with the patient as much as I can, and troubleshoot it with them before I go and run to the physician and tell on them, because I think that oftentimes I can help the patient come up with some level of solution with improving their medication compliance, as opposed to just needing to report it to the physician. So my first line of attack is for sure to try to troubleshoot that with the patient. But if I'm not getting anywhere there, then yes, my next step would be to report it to the primary care, especially like you said, in the setting where it feels like their glycemic control is really inhibiting our healing, or their edema control, or, those are real common examples that we'll see, or they're not taking their antibiotic because they couldn't afford the copay. Those are tough situations. And if I can't reconcile that with the patient specifically, then yeah, you do have to take that to the physician.
Okay, great. Well, Dawn, this has been an excellent presentation. Even for those experienced in wound care, you can't go over this stuff enough to remind you of, especially your zoom out, taking the patient as an individual and looking at all of their comorbidities and everything, not just that wound, because we do always want to focus right in on the wound and do something to it. So thank you again. I'll turn this back over to